development was a huge achievement in the world of ophthalmology. Optical principle. Optical design of the fundus camera is based on the principle of the monoocular indirect optometry. Fundus camera provides an upright magnified view of the fundus. A typical camera views 30 to 50 degrees of retinal area. What are the indications of color fundus photography? Documentation and monitoring of eye disease such as diabetic retinopathy, age-related macular degeneration, glaucoma, and neoplasm of the retina or choroid. Screening of some diseases like diabetic retinopathy screening and glaucoma screening. Anti-malarial therapy by noting the changes in the heart. Emergency cases, including patients with constant headache, acidic pressure more than 120 millimeter of mercury with sudden visual loss. Now, the procedure of color fundus photography. There are many procedures of the color fundus photography, but we commonly use standard fundus camera. And there are other procedures, that is ultra wide field fundus camera, portable fundus camera, and smartphone with a special device. This is the picture of the standard color fundus camera we commonly use in color fundus photography. This is the latest ultra wide field color fundus photography, and this is portable fundus camera with the street lamp. Standard color fundus photography uses a high resolution camera and a focusing system to take image of the posterior pole. These systems try to replicate what practitioners see the fundus. Thus, a similar white light resources is used. This makes interpretation of the fundus photographs and future comparisons to the fundoscopic view. Most eye care professionals tend to order 45 to 50 degree image centered on the fovea. This allows one to visualize the macula, optic nerve head, and retinal nerve fiber layers in one image. Some instruments also allow the operator to decrease the angle of view of 35 or 20 degrees to improve resolution. This can be used when small or focal lesions need to be imaged with increased clarity. Ultra wide field color fundus photography. This is the newer models of fundus camera allows to mask larger areas of the retina to be imaged. Though there is no standardized nomenclature, wide field and ultra wide field photographs commonly refer to 100 and 200 degree angles of view respectively. Ultra wide field systems can image a significant portions of the retina, allowing clinicians to monitor peripheral lesions that could be clearly imaged with standard fundus photography. Photo documentation of the peripheral lesions such as lattice degeneration, holes, or blue retinal scars simplifies follow-up management, helping ensure that there are no pathological changes in evidence. This is the color fundus photography of the standard fundus camera, and this is the ultra wide field camera. Here, about 200 degree visual field can be seen at a time, and it can also in non-micromatrix location, it can also possible. And this is the normal standard color fundus photography picture, and air field is about 45 to 50 degrees. It is 200 degree in ultra wide field camera, that is 82%, and 45 degree in standard fundus camera, that is 15%. The role of color fundus photography in eye care. In eye care, we are lucky to have many diagnostic and imaging modalities available to us. Color fundus photography is a relatively old technology. It still has it in the ophthalmic practice. Many common diseases can be detected and managed in primary eye care. Some examples of the diseases noted by the color fundus photography. This is color fundus photography of the right eye. This is healthy retina, and this is diabetic retinopathy. That is hemorrhage, microaneurysm, and heart-related patient. And this is the color fundus photography of the non-proliferative diabetic retinopathy, and this is the color fundus photography of the proliferative diabetic retinopathy. Here, new vessels present here, and here is no new vessels. That is heart-related patient and hemorrhage patient. There is retinal edema, non-proliferative diabetic retinopathy. And this is new vessels elsewhere, and this is fractional retinal detachment. This is the glaucoma protocol. Here, this is, and this is the papillitis. Here, obliteration of the optic cup, and this present, and also this margin is ill-defined. And here is the picture of papilloedema, and this is the picture of optic atrophy. Here, chalky white color and margin is well delineated, and there is grayish white color and margin is ill-defined. And non-diabetic optic neuropathy, that is hyperemic stadium. And it is optic is frozen, and it is optic is coloboma. This is the picture of CNVM, and this is the picture of age-related macular degeneration. They are frozen present in retina. And this is the central serous fluid retinopathy, that is neurosensory retinal detachment in the macular area. And this is the macular hole, deep red punched out lesion at the center of the macula. And this is the picture, color fundus picture of the cystoid macular edema. And this is the picture of histomacular traction. This is the picture of bone dystrophy, and this is the picture of central retinal vein occlusion. Here, hemorrhage present, exudate present in all four quadrants. Also, dilatation and proximity of the present. This is the branch retinal vein occlusion. Here, hemorrhage and exudate present, and also quadrant and also macular area. And this is the color fundus photographic picture of the central retinal artery occlusion, that is part of the macula is supplied by secluded artery, which is normal. This is the picture of vasculitis retini, which is vascular retini present. And this is the retinopathy optimal is demarcation line, that is stage 1, and it is the stage 2. This is the color fundus photographic picture of retinoblastoma and the choroidal melanoma. Retinitis pigmentosa is early stage and is having early stage. And that is degeneration present. And this is the ear and operculum phase. And this is the rhegmatogenous retinal detachment, that is grayish white retina comes forward along with muscular pattern. This is the retinal detachment. Advantage of the color fundus photography is non-invasive procedure, it is cost effective, easily performed, rapid procedure, and patient satisfaction. Disadvantage of the color fundus photography: no accurate diagnosis, needs clear media, and it is two-dimensional view. Now, conclusion. Color fundus photography, though an older technology, is still a vital component of any ophthalmic practice. Detection and documentation of posterior-segment structures are crucial in disease management. More advanced change of the color fundus photography further increase the utility of this technology. Thank you.
Thank you, Dr. Sudhir Kumar Sarkar, sir, for your very nice presentation on color photography. And actually, color photography is needed for publication and for the reference. Very nice presentation. And I would like to request our next presenter, Dr. Amin Biswan, sir, to present his topic on fundus fluorescein angiography. Sir, please.
Thank you. Thank you, Dr. Sundar.
স্যার কিছু কি বলবেন? সাইফুদ্দিন আমিন পিন্টু স্যার কি কিছু বলবেন? স্যার আপনার হ্যান্ড রেজ করা আছে স্যার, আপনি যদি কিছু বলেন স্যার। সাইফুদ্দিন আমিন পিন্টু স্যার কিছু বলবেন না স্যার?
থ্যাংক ইউ।
সঞ্জয়,
স্যার
আগে তুমি ওই যে প্রেজেন্টেশন শেষ করো, তারপরে
স্যার না স্যার, স্যার হ্যান্ড রেজ করে আছেন তো স্যার, ঠিক শিখেছি।
Thank you. Thank you. Good afternoon and Assalamu alaikum to the chairman and honorable penalty and dear audience. I'm Dr. Amil Nafis, a professor. My topic is fundus fluorescein angiography. I think I will complete this session with short in time. Fundus fluorescein angiography is very, very important in our region, that means retinal imaging. I think physical fluorescence, we know the property of certain molecule to emit light energy of longer wavelength when stimulated by short wavelength. We know that what is luminance, so we have to know before to understand that is luminance, what is fluorescence, what is phosphorescence. Luminescence, emission of light from any source other than high temperature. That is luminescence. And fluorescence is a luminescence that is maintained only by continuous excitation. And phosphorescence is luminescence where the emission continues long after the excitation is stopped. Now, soda fluorescence, we know it is yellow on its color, highly water soluble, inert, normal with 376 Dalton, it is black phase, peak evolution 465 to 495 nanometers, emission 520 to 530. Dazzle diffuses also outer and inner blood-brain barrier. The most important point is here, 80% we know 80% bound to plasma protein and also with the RBS and is not available for fluorescence. Remaining 20% of unbound fluorescein is responsible for the fluorescence seen during the angiographic procedure. So we know that remaining 20% is responsible for that is a fluorescence angiography picture. Doses we know 5 ml 10%, 3 ml 25%. Evaluation of the vascular integrity of the retina and also choroidal vessels. Check the check the integrity of the blood-brain barrier, outer blood-brain barrier and inner blood-brain barrier. Indication, retinal vascular disorder, macular disorder, retinal vascular malformation and tumor, choroidal disease, retinal disease. Special situation is very important in pregnancy, and that's controversial. That is, fluorescence doesn't cause the placenta. Angiography has been performed in pregnant women patients with no significant adverse effect. Nevertheless, it is best to avoid that
Hello.
আমিনুল মনে হয় অফলাইনে চলে গেছে।
স্যার আমি কি নেক্সট প্রেজেন্টেশন কি যাব স্যার? স্যার আসলে অবশ্যই করা যাবে।
কানেক্টিভিটিতে প্রবলেম হচ্ছে
আপনার তো স্টপ শেয়ারিং লাগবে, স্টপ শেয়ারিং।
ওয়াইফাই প্রবলেম
একটু ওয়েট করুন, একটু ওয়েট করুন।
একটু ওয়েট করে চলে আসবে
আমিনুল কি শুনতে পাচ্ছ?
স্যার আপনারা আউট হয়ে গিয়েছেন স্যার। নাই দেখতে পাচ্ছি না, স্যার।
আমরা কি
তোমার কাছে আমিনুলের টেলিফোন নাম্বার আছে না?
আমি একটা ফোন দিচ্ছি।
ওটা বলো যে তার যদি ওয়াইফাই লাইন না থাকে তাহলে আমরা অন্যজনকে দিই।
অথবা আমরা অন্য পরের দিনটা শুরুতে শুরু করতে পারি, ওকে আবার হাফ অফ দিস প্রেজেন্টেশন লাস্টে করতে দিতে পারি।
স্যার কোনো প্রবলেম স্যার? স্যার তাহলে কত সময় লাগবে স্যার? স্যার উনি ওয়াইফাই সমস্যা ছিল স্যার, মডেম ইউজ করছেন স্যার, কিছু সময় মধ্যে চলে আসবে আসলে।
সন্ধ্যা
স্যার আমরা একটু ওয়েট করতে পারি স্যার?
হ্যাঁ, শোনা যাচ্ছে, চলো।
আমি স্যার চলে আসছি।
আছে আবার শেয়ার করতে হবে।
জি স্যার।
ফুল ভিউ দাও।
স্যার আপনি শেয়ার দেন স্যার। স্যার আপনি আনমিউট করবেন স্যার প্লিজ। স্যার
আনমিউট করতে হবে ভয়েসটা।
আমাকে আমি আই থিঙ্ক আমি শর্ট করি উইদিন শর্ট পাচ্ছে না হ্যাঁ অর্ডার ফেজ we know the phases of the normal angiogram as a 2000 where me
শোনা যাচ্ছে? বুঝতে পারছি স্যার।
phase of the non আমি শেষ করি phase of normal angiogram we know everybody knows that there is preatrial phase, arterial phase, arteriovenous phase, venous phase and late phase. Order phase after injecting first image we taking 10 to 12 seconds after injecting 12 seconds after injecting, that is first phase preatrial or caudal phase. This caudal phase caudal phase and to take in the preatrial phase is only take 1 second. And this is arterial phase that is arterial phase and not in venous filling, only artery that is hypertension. Arteriovenous phase that is again important. Then laminar flow এখানে laminar flow দেখা যাচ্ছে, this is axial the hypotension strip in the venous, the vein in case of the arteriovenous phase. And in case of the early venous phase, there is pressure of the laminar flow, and in the mid venous phase, all on venous filling except remaining laminar flow that is present here. And in late venous phase, all the vein is filling with fluid. There is no laminar flow here present. In late phase, we know gradual inhibition of the diaphragm, caudal and retina circulation. Staining is normal. After 30 seconds, injection first high concentration, vagus empty and recirculation takes place. This is completely empty of fluid approximately 10 minutes. Phase, caudal phase 10 seconds, arterial phase take picture 10 to 12 seconds, arteriovenous 30 seconds, early venous 14 to 15 seconds,
mid venous 6 to 17, late venous 18 to 20, and elimination will late after 5 minutes. This is autofluorescence. Now I discuss about the hyperfluorescence. Hyperfluorescence. Hyperfluorescence first of all, autofluorescence. There is a without dye when there is a fundus camera, a compound camera absorb light and emit the green yellow light, and same fashion like to the fundus fluorescence. This autofluorescence. Fluorescence, there is optical fluorescence, there is optical fluorescence, and we know the hyperfluorescence also is in case of cooling. Cooling, there is the subretinal and sub-RP. This is subretinal, there is interference retinal detachment. This is cooling. I discussed this later. And pigment epithelial is sub-RP. There is two types of subretinal and sub-RP. This is RP. This sub-RP is different. Leakage. Leakage system mechanism is the vascular leakage, and subretinal revascularization. Leakage from the break of the inner blood area, or the hemangioma, staining, prolonged of the leakage, staining. Then this case there is a multiple hyperfluorescence. Hyperfluorescence, we know the physical hemorrhage, that is blood fluorescence, interstitial hemorrhage, also blood fluorescence, the interstitial hemorrhage, hemorrhage in the retina, and the subretinal hemorrhage, looks like subretinal hemorrhage. They also blood fluorescence. And now I show some image on the screen from NIO. That is a patient, 45 years, that is showing that is a leakage to the fovea, and this in case leakage fovea, and this is CSR. But it is mentioned that though in case of the CSR, sensory retina, it is not filling with the dye. It is very, very important. Only leakage is shown. Yeah. And it is also PD, even epithelial detachment, and for further new vascular, there is leakage and hyperfluorescence, and also there is a hyperfluorescence in between hyperfluorescence. This is a image of diabetic related diagnosis, and it's shown the early that there is a microaneurysm, huge microaneurysm, and capillary dropout, and leakage of this leakage. This is a very, very important case. This is a caudal devasculation. There is a leakage center, but outer hyperfluorescence, there is a rim of the hyperfluorescence. Very, very significant in case of the wide variety of the ARMD. We know there is due to the hyperfluorescence or block fluorescence is due to the subretinal hemorrhage. There is also caudal nevascularization, that is center block fluorescence due to the retina, due to the subretinal hemorrhage, and for CNBM, and also there is a pigment epithelial detachment, which is unmasking the caudal flush, and it is important understanding that by the pulling and leakage is present here. Pulling, that means pigment epithelial, the PD, the detachment, and there is a leakage due to the blood retinal barrier. And it is a case of the pulling by the diabetic retinopathy, That is show the huge neovascular membrane, that is show the leakage and also particularly dropout, and filling, that is capillary dropout. This is also case of this distal macular clinical stigmatized macular edema. That is, we know the heart disease is not seen with the fluorescence. There is no seen in the color fluorescence. We also seen in the microaneurysm. There is multiple microaneurysm and leakage, and also the ischemic area like capillary dropout. This leakage. And this is the case of the severe non-proliferative diabetic retinopathy, which is also the heart disease, and huge multiple microaneurysm, hypofluorescence clot, and leakage is the late stage, that is the case. And is a block fluorescence, we know that fluorescence, there is a prenatal hemorrhage, but this, the retina is not shown for block fluorescence. And it is an important case of the patient of 20 years. This patient came to me, Imran Sheikh, here both eyes present his blood condition. This is Stargardt macular dystrophy. What is it? Frequent apical atrophy, and that is intensity and size is same. That is not in case and size and in size. This is due to the window defect. It's very example of window defect in Stargardt macular dystrophy. This is a patient of another patient. This is the RP atrophy. First of all, hypofluorescence, that is late staining, that is hyperfluorescence, and there is multiple dot-like hyperfluorescence due to fluorescence. This is due to dry eye. And there is a high magnification of the pattern to see any leakage, microaneurysm, that is ischemic area. Thank you. Okay. Thank you.
Thank you, sir, for your nice and elaborate presentation on fundus and therapy. Now, our next presenter, Dr. Hafizur Rahman sir, to present his topic on OCT angiogram. I would like to request Dr. Hafizur Rahman sir to present his topic on OCT angiogram. Thank you, sir.
I think he is the last speaker.
No, sir. Sir, we have another speaker, Dr. Shahanur Hassan.
Am I audible?
Yes, sir.
I think we should maintain time, please.
Sir.
Respected panelists, moderator, learned ophthalmologists who are in the screen. Assalamu alaikum and good afternoon. I am Dr. Mohammad Hafizur Rahman, presenting my topics OCT angiography. At first, I want to say about OCT angiography. It is new non-invasive diagnostic method through which the vascular structures of the retina and choroid may be visualized in 3 dimensions without need for contrast agent. What is the basic of the OCT angiography? OCT angiography is based on the principle of diffractive particle movement detection, such as red blood cells on sequential OCT scans performed repeatedly at the same retinal location. The same presence of blood vessels. Sorry, I have not shown in the remarkable point because precursor of my laptop is not working now. An OCT angiogram machine captures multiple conventional structures, OCT images at the same site of the retina, then it compares with the resulting difference between them. If the imaged area is vascular, intravascular turbulence will causes differences among the multiple images. If the imaged area is avascular, no difference among the multiple images will be detected. Segmentation in OCT, we take vertical scan that can we use to, but in OCT angiogram we take the horizontal scan. In this horizontal scan, we found 4 layers, such as superficial inner retina, that is the large retinal blood vessels from internal limiting membrane to inner plexiform layer, and deep inner retina, that is the small retinal blood vessels from inner plexiform layer to outer plexiform layer. Outer retina, there is no retinal blood vessels here. That is the outer plexiform layer to Brooks membrane, and at last capillaries. That is the some small choroidal blood vessels from Brooks membrane to about 40 millicentimeter below. This is the superficial and this is the deep retinal capillary plexus. This is the outer avascular layer in left side and right side the capillary layer. This is the color-coded composite OCT angiogram. This is the superficial layer, that is the red color. Deep retina, this is the blue color. Capillary, this is the green color, and outer retina, this is the white color. We can use OCT angiogram in different diseases in our daily practices, such as the ARMD, that is the white and dry, diabetic retinopathy, arterial and venous occlusive disease, CSCR, pigmentometry, glaucoma, and some anterior segment disease like as the cornea and conjunctival and iris blood vessels. I want to see some clinical interpretations now. Here, the color fundus photography and early and late phase of the fundus process angiography. My precursor cursor is not working now, so I have not seen you. And OCT angiography. Fundus process angiography is the small change in the macular reflection, that is the macular intrusion. Fundus process angiography, early phases non-homogeneous hyperfluorescence. Late phase, hyperfluorescent stain but no obvious leaking. And OCT showing the disordinate PED with the mild subretinal fluid. And that is the 3 mm scan passing through the choroid. The neovascular network is formed. A dark lesional ring around the network indicates vascular insufficiency surrounding the new vessels. This is the type 2 neovascular AMD. The fundus process angiography and OCT both shows a choroidal neovascularization in OCT dome. That is the appears as the rounded lesion with a sharp edge. Scan passing beneath the plane of the retinal pigment epithelium. At this level, the new vessels and the retinal vascular network are superimposed. This is due to the projection effect, which is in the provide a replication of the retinal vascular flows, while the neovascular flow at the level below the actual flow. This is the type 3 or neovascular AD. Fundus photography shows hemorrhagic located in the vicinity of small region at the posterior bone. The macular mapping shows a macular thinning that is also decentered infratemporally. And fundus process angiography, that is the right row, right and left, that shows the non-homogeneous fluorescence around the hemorrhagic area. OCT shows the anastomosis with the hyperreflective lesion, making a junction between the retinal pigment epithelium and sensory retina. But OCT angiograms showing some lesions which are the intercommunicating. CNBM of subretinal PD, the color fundus OCT, and OCT showing CNBM with the subretinal hemorrhage. In first picture, fundus process angiography showing block fluorescence due to hemorrhages and diffuse leakage from the new vessels here, but details are not visible. In OCT angiogram showing no lesions present in superficial capillary layer. In deep layer, apex of the extended lesion in present. RP and avascular layer and the choroidal layer morphology of the new vessel are present clearly in OCT, but there is no changes in the color fundus of OCT and fundus process angiography. This is the myopic CNB color fundus photograph showing a paracentral atrophic lesion. There is a grayish lesion. OCT scan passing through the neovasal and neovascular lesion. There is a hyperreflective aspect of the deep retina associated with the thickening of the sensory retina. OCT mapping confirms the presence of the supramacular thickening, but OCT angiogram showing the scan passing, which is through the retinal pigment epithelium, showing the neovascular network corresponding in the neovascularization in the periphery that lies in the macula. This is the fibrotic syndrome, the OCT angiogram image of the capillary segmentation and corresponding scan showing the large dark area. This is the center. My precursor is not working, so I have not seen. Scan showing the large dark area which are due to the diffuse lack of the signal within the flow of the network. This is the picture pre and after treatment of the CNV after giving the NTPJ. This is the randomization. OCT showing the markedly reduced neovascular after giving NTPJ. So we see OCT angiogram as not only the qualitative but also the quantitative function. There is some limitation of the OCT angiogram. This is the microneedles are not perceived in the both superficial and deep capillary networks because of the slowest detectable flow in microneedles. This is the limitation of the angiogram. In case of the diabetic macular edema, OCT angiogram shows, and here the pictures showing the color fundus and vertical OCT and all layers of the OCT angiogram. But I only highlight the only OCT angiogram. OCT angiogram showing the vascular lobes and cysts in both superficial and deep plexus. Scan passing through the deep capillary plexus shows more pronounced cystic space associated with the capillary impairment. It is noted that there is no capillary network within the cystic space. In case of proliferative diabetic retinopathy, this is the case of the proliferative diabetic retinopathy. We see the NPT and NB here, color fundus photography and OCT angiography. There is no leaking seen in the OCT angiography, but clearly seen the neovasals. You can see capillary non-perfusion area in between them. In case of OCT angiography of the macular area in PDR, the scans passing through the superficial and deep retina show the disorganization of the macular and perimacular capillary network. Transretinal occlusion, the photograph for 4 layer of the color coding OCTA and color fundus and OCT macula, but OCT angiogram at the level of the superficial and deep vascular networks showing the enlargement of and disruption of its normal control. Non-perfusion area is more, vascular loop and dorsosity are also the present here. In case of central retinal veil occlusion, OCT showing the hyporeflective areas that represent the retinal cyst, and OCT angiogram at the level of the deep vascular network showing the lack of OCT signal in well-defined rounded or area in the center, which are saying oblong areas in the smooth borders corresponding to the interretinal cyst. In case of central retinal artery occlusion, the color fundus show a whitish appearance of the macula and the entire posterior bone. The macula appears dark cherry red spot, and angiography in the similar regions that demonstrate significant changes in capillary network and overall the capillary impairment. The deep capillary plexus is not visible, replaced by superficial capillary plexus. This is also the projection artifact. Transretinal artery occlusion here. Then the OCT reveals the inner retinal atrophy infratemporally to the macula, but OCT angiography shows decreased capillary perfusion in both superficial and deep retinal capillary networks. Arteries and arterioles remain perfused over areas of the ischemia. In case of CSCR, till now, fundus fluorescence angiography is the main investigation tool for CSCR, actual linking point seen by fundus fluorescence angiography. But the superficial OCTA scan shows no major anomaly of the retinal capillaries. In deep capillary layer, we see a large shadow as avascular appearance due to collection of fluid, but not seen any leakage or pooling. This is also another limitation of the OCTA. In case of PD, in OCT shows the optical empty space present beneath the retinal pigment, but OCT angiography reveals the image of the neovascularization may be seen on the scan passing beneath the retinal pigment. The The neovasculature is clearly visible on the dark background. Yes, as by the distance between the layers of the retinal pigment epithelium and the choroidal plate.
Sorry, sir, for interruption, sir. Time is running short, sir.
Okay. Okay. Okay, I'm short. In OCT glaucoma, the healthy retina eye envelops the oblique equivalence tomography image of the radial peripheral capillary layer, that is seeing. But second picture, retinal fiber layer images are shown. Advantage: penetrates OCT angiogram penetrates through the hemorrhage and retinal pigment epithelium, but FFA, ICGA, or color fundus photography is not possible. Demonstrable both retinal and choroidal vessels, no invasive, no injection of no contrast agents, one-dimensional, and taken only the 3 to 4 seconds. But in color and fundus process angiography taken the 15 minutes. And some disadvantage: the small field of the view, 3 by 3 or to 8 by 8 millimeter. Field will increase with the higher speed. And there is also a problem, but scientists are working to increase the area. But fundus process angiography showing the peripheral area. But this is also the problem of the OCT angiography. And some microorganisms without flow could not be visualized. OCT angiogram did not provide flow information such as filling, speed, leakage, dye pooling, and tissue staining, which are previously I have said. And cannot detect too slow flow or too fast flow, and subject to artifacts that like is the motion artifacts and data tracking, which is the shadow artifact checker and board artifacts. This is the problem of the OCT angiogram. And thank you very much for your patience sharing.
Thank you, sir. I am going to our next speaker. Before I go to our next speaker, I would like to give thanks to Dr. Hamidullah sir because this is the only and he has nicely presented the topic. And our next presenter, Dr. Shahur Hassan sir. I would like to request Dr. Shahur Hassan to present his topic on the HSAM 3D vision system. So, anyone topic here, I would like to request. Thank you, sir.
Am I audible?
Okay, sir. Audible, sir.
Okay. Assalamualaikum, esteemed panelists and the audience. Be very short. It will be around 4 minutes presentation. This is a new topic actually. The 3D visual system. I'll be just highlighting on some things about it. What is heads-up vision system? It's a state-of-art vision system enabling to perform intraocular surgery literally heads up. That is why we are not using the normal eyepiece of the microscope. Our heads are up, and it is via a 3D stereoscopic high definition digital video camera displayed on a high definition monitor. That is, a TV screen is there, around 55 inches monitor is there, and you're sent on the monitor and doing our surgery. We all, of course, use a polarized spectacles, which gives the 3D effect. So polarized spectacles are used that replaces the oculars. So this is the 3D vision system with monitor we have in Bangladesh Eye Hospital, Dhanmondi. We have been practicing it for a couple of months, and you can see here, you can see the monitor and the phaco machine. Of course, on the left hand side, you can see the glasses. There's a polarized glass, and of course here the microscope. I will later show you that the eyepiece is not here, as you can see. So this is the polarized glass that can be used for the surgeon and assistants, and of course the observers and trainee doctors. Even the attendants of the patients can, if they want to see, they can attend the OR and see this OT in 3-dimensional view. And of course that oculars is not there. That is, we are used to use this thing, this is a conventional one. And on the left hand side, you can see that part is absent. Actually, this is the same microscope, the Zeiss microscope, where we can actually feed the oculars, and we can, without it, we can also do this 3D system what we're presenting. This is an ongoing surgery I'm doing on the 3D vision system. As you can see here, the ocular is like, I'm not using it. You can see here that I'm not using this ocular. It is here. It's not used, and my vision is actually towards the TV here. So it's like around 6 feet distance is here. My assistant is sitting here, and my assistant is also having a direct view to the TV monitor here. So it's a big monitor, and the view is very good actually. And this is another surgery I'm doing on phaco emulsification, just to show that both the anterior segment and posterior segment surgery can be done in this system. I'm audible.
Yes, sir.
Okay. So this is just a picture of me wearing a sunglass in the dark room. Actually, we wear sunglasses in bright places, but here is completely different. The room is usually darkened so that the view is better. And this is a polarized glass I'm using. Different models are available, but in Bangladesh Eye Hospital we have this RTO 800 that is from the Zeiss. There's also a model called Ingenuity from Alcon and True Time. Another model is coming. It's the Bionic model where we don't need even a TV monitor. We can use it to the active glasses or polarized glass. That active system, wearing the glass, you can see the things in the glass itself. We don't need a monitor. That is still not here in our country. The advantages, main advantages of the better ergonomics, that is the sitting position, as we are not bending like seeing in the eyepiece or oculars. It is more comfortable, particularly where long surgeries is there. You know that in retina surgeries we have to perform, it takes some time, and even in phacosurgeons or busy phacosurgeons doing a couple of surgeries in the same sitting, it is good for them because the ergonomics is better. Improved magnification, no doubt, because the screen is big and the magnification is automatically big. Wider depth of field, that is very important, and this is very noticeable when you do this surgery. The first thing you'll find is the depth. The first thing will hit you when you do the surgery. You have a very good depth, and when you have a very good depth, your surgery safety is increased because you're seeing the anterior capsule, posterior capsule, it will be very deep. You can feel the space around you. Larger field of vision, that is very interesting because the magnification is big and the field is also big. We usually see that when the magnification is big, the field grows small. But here we have a larger field and a larger magnification. Reduce phototoxicity because we need less light. We can see better in less light. And of course, last but not the least, it's a very good educational tool, particularly for our residents and our trainee doctors. There are some drawbacks. There is a small learning curve. You need a couple of surgeries to get used to it. Initially, it takes a larger surgery time, but when you get used to it, it's almost the same. Sideway view, this is another thing because you cannot see straight. You have to see sideways. So either left side or right side your screen is there. So this is a bothering thing sometimes because if it was straight view, it would be much better for the surgeon. The comfort level would have been much better. And of course, some OT theater logistic and wire problem because the wires and they are the TV monitor, wires and all these things. So you need a bigger OT and a good positioning of the OT structures. That is the TV, microscope, and the monitors. All these things you need to be in a better position. And assistant discomfort is sometimes there, but eventually it goes away. The need of 3D is more nowadays important because there are robotic surgeries in other subspecialties, specifically urology and other surgery. Robotics is there in artificial intelligent overlays, image guided surgery, that is here in our ophthalmology. We do image guided surgery with the OCT. Still not available here, but abroad we are seeing the OCT guided surgeries are there, particularly in macular hole surgeries or eye opening surgeries. Telemedicine, all these things can be integrated in this three-dimensional vision system. But the hybrid technology is there. That means when you're doing a 3D, that doesn't mean that you're stuck to it. Surgeons can switch to oculars anytime in between surgery. So it does not restrict the traditional vision system at any point of the surgery. This is just a thing I want to share. This surgery is a 3D surgery, but unfortunately, you cannot see it 3D. Hopefully, when we do a physical conference, I'll be able to give you polarized glasses. But you can see the view. The view is more or less, I'm not just normal view, I'm not adjusting the microscope, I'm not doing anything. It's the normal view you have in the 55 inches big screen when you do this surgery. So you can imagine the clarity of the depth. I can see the retina, I can see the vitreous, there's a PVD induction. It's much more easier for me. So of course, you can do it in this oculars, using the oculars, but the three-dimensional view is excellent, particularly in macular hole surgery. It gives you comfort, it gives you safety, and all the things, the forceps, maneuvering, all these things are much more. Even the air fluid exchange, because the vision sometimes goes away when the air is there. The air fluid exchange is also excellent. The view is always there. And just this is surgery. The second surgery is there are two surgeries going on simultaneously. The left hand side, that is Mr. Zubair Ahmed, is on this normal system, traditional surgery viewing system, and the right hand side you can see the 3D viewing system. You can see the field of of view is much better in the 3D visual system, and you can see that the maneuvering is much better for me. I'm more comfortable, and my hands are more less shaky when I'm doing this 3D maneuver because it's much better for me. You can see how nicely I can see all this thing, and I can actually do this because when the view is bigger and magnified, everything is better. There are some latency time issues. It was previously there. That means when you're seeing something and doing it, sometimes a fraction of seconds, sometimes you feel that it is not the real time. But that problem is now in our new version, what we are using in Bangladesh Hospital, we don't have that problem. The new updated version, we have no latency time. That is, so it's like a real time surgery you are doing. So you don't have any problem when seeing in the monitor while doing the surgery. In my concluding remarks, I would like to say that we believe only what we see. We deeply believe what we deeply see. In 3D head-up vision system, the vision is deeper, wider, and brighter. So let's all embrace this high-tech vision system, not only for us, but also for our trainees who are our futures. I want to thank OSB for giving me the opportunity to share this talk. Special thanks to Bangladesh Eye Hospital and Institute, my mentors, Dr. Mahabhuraman Chaudhary sir and Niaz Abdurrahman sir, gave me the opportunity to do this 3D surgery. Thank you all.
Thank you, sir. Thank you for your such a nice and newer technique in our country. Sir, now this is the time for our panelists. Time is very short, and I would like to give 2 minutes for each panelist for speaking of for the topic. Now, at first, I would like to request Professor Nujhat Chaudhary Madam to speak on color fundus photography, which was presented by Dr. Sujit Kumar Sarkar. Madam, please.
Thank you, Sanjay. I would the exact topic that you have asked me to speak. I was having net problem then, but I would like to just in brief talk about all the presentations. 2 minutes. Excellent presentations, and thank you for thanks to OSB for giving importance to the imaging system, which is actually like our third hand for the retinal specialist. Only one point I wanted to make is that when we talk about images and when we present in such a manner as if whatever I'm presenting, and that is the gold standard. You know, to me, the way I see it is that no one particular imaging system is 100% end all or be all. You know, they are not exclusive of each other, but they are complementary to each other. It depends on what I'm trying to look for, what is my disease, what is the endpoint that I want to see. So every imaging system has its benefit, but it also has its shortcomings. Like OCT-A has come, Opta-A has come, but the field is not that good. So if you want to see the diabetic retinopathy, you can't go that far. But you know, to see the endpoint of treatment in wet AMD, OCT-A is so good. So we can incorporate all of it, but no new modality of imaging has yet been good enough to replace FFA or OCT. You know, not all the pathologies are vascular, so we need the structural visualization that we find through OCT. So all these imaging systems are complementary to each other. They are not exclusive of each other. They don't exclude, one doesn't exclude the other. They're complementary to each other. It only depends on the surgeon or the retina specialist what I want to find out, what I want to see. So thank you very much, everybody, for a very nice presentation. And of course, the last presentation of head up 3D vision. This is the future probably, but we should always, always keep the economic side in mind as well. So I do not believe that we are jumping to 3D at any point soon, but of course, maybe that is the future. So thank you everybody for brilliant presentations and for enlightening us again, and we all recapitulated the imaging system. Thank you very much.
Thank you, madam. Now, I would like to request Dr. Niaz Abdurrahman sir, because sir is going to another meeting, so I would like to implore Dr. Niaz Abdurrahman sir to speak on heads up 3D vision system, which was presented Dr. Shamar Roshan sir. Sir, please.
Thank you. আমাকে শোনা যাচ্ছে?
জি স্যার, শোনা যাচ্ছে স্যার।
Oh, thank you very much for inviting me to this session. It was a very good session. First of all, I'd like to say that these are the kind of sessions that should be arranged because it has a mixture of very basic information, but like color funnels, photographs, and angiograms, OCD, and also at the end we saw what's the present, high-tech investigation, not high-tech I would say, but the present important investigation going on, that is OCT angiogram and the latest kind of surgery, that's 3D heads of surgery. So this was a mixture of both. This session was for everybody, and I'd like to just impress upon everybody that fluorescent angiography, color funnel photography will always be there. OCT angiogram ashuk at OCT ashuk, you have to, all youngsters, especially residents and everybody, young doctors must learn fluorescent angiogram very well. And color funnel photograph, that is a part and parcel of retina. So এটা আমাদের থাকতেই হবে, color funnel photograph and fluorescent angiogram. We must learn fluorescent angiogram. OCT has revolutionized everything. OCT থেকেই সবকিছু শুরু, OCT আমাদের জানতে হবে। Now OCT angiogram is also very, very important. OCT angiogram, OCT angiogram which is here now. OCT angiogram is available in Bangladesh, in Dhaka, outside Dhaka, and we should all learn and start using this modality. Hafiz's presentation was very, very good. In fact, in Hafiz's presentation, I myself learned a few things. Thank you, Hafiz, for such a nice presentation. And the 3D heads of surgery is just a wonderful surgery, as Dr. Shanur has shown. What the important thing is that the resolution in the whole system is much higher than what we can see with the oculars. Therefore, when you get used to 3D surgery in that big screen, you can do surgery, especially retina surgery, where you're doing membranes, peeling membranes, dissecting membranes. You can do it with much more confidence. 3D surgery, it is a very expensive proposition. It is an institutional based system. এটা কেউ একটা প্রাইভেট চেম্বারে কিনলে এটা টাকা পয়সা উঠানো যাবে না, and not a good investment from the business point of view, from the investment point of view. But all institutions should now have 3D surgery. একবার মনে হচ্ছিল যে ফেকো মেশিন কেনা যাবে না, আমরা এসএসসি করবো, এত দাম। এখন ফেকো মেশিন ইজ এভরিওয়্যার, কিন্তু এইটাও কেনা যাবে। আমার মনে হয় all institutionকে encourage করা উচিত, bigger institutions to go into the 3D heads of surgery, because it does have certain advantages which the others doesn't, and especially it is a wonderful learning tool. Thank you very much. I have to attend another meeting, so I'm leaving abruptly without hearing everybody's comments. Thank you, OSB. Thank you, Sanjoy, for coordinating the whole meeting. সবাইকে ধন্যবাদ। সবাইকে দেখলাম, খুবই ভালো লেগেছে। আজকে ওএসবির অন্যান্য সেশনে, আমার ওটির ভিতরে আমি inaugural সেশনে সব জায়গায় ছিলাম। নুজাত, you were there, very nice. I heard you talk. Thanks everybody. আবার দেখা হবে। ধন্যবাদ।
Thank you, sir. Thank you, sir. Thank you very much. Sir, now I like to request Professor Colonel Mushahid Thakur sir to speak on fundus fluorescent angiography presented by Dr. Mohammad Ahmed Hussain sir. Sir, please.
Assalamu alaikum. Thank you. Can you please hear me?
Yes, sir.
It's a very nice session, and every speaker spoke very nice, and they have disseminated very informative news regarding the retinal image and others. So far as probably I am the only panelist from outside Dhaka, so many thanks for keeping me as a panelist. Regarding angiography, fundus fluorescent angiography, OCT angiography, he spoke very nice. And he also touched many points. I think the participants as well as me and others will be benefited. But at some point he mentioned autofluorescence. It's a very nice point. But I think he missed to mention retrofluorescence and pseudofluorescence. It is also essential. However, in this session we learn a lot, and thanks to all the speakers, all the arranger, all the organizer, and especially heartfelt thanks from me. And another point, color fundus photograph, though it is not within the arena of my speech, he mentioned many things. Color fundus photograph, especially in corona situation, when we cannot go close to the patient with direct or bulk lens procedure, it is very essential in corona pandemic situation. We invariably advise the color fundus photograph for the patients. And at one point he mentioned probably anti-malarial drug we use for a short time. So in this short period, anti-malarial drug does not cause maculopathy. Probably he wanted to mention SLE. In SLE, we have to use anti-malarial drug hydroxychloroquine or chloroquine for a pretty long time. It causes maculopathy or bullseye macula. However, overall, this session is very useful. I think all the people, all the ophthalmologists will be benefited. Thank you all.
Thank you, sir. Almost sir, now I'd like to request Professor Deepak sir to speak on OCT, which was presented by Dr. Mohammad Shahidul Islam sir. Sir, please.
Thank you, Dr. Sanjoy, and thanks to everybody who has spoken in this session. Actually, it's a OSB presentation, so I thought that it should be very basic, and what the speakers say is absolutely they are very successful in their talk. Regarding OCT, just I would like to mention one thing that Dr. Shohid mentioned very rightly, that we see the line scan only. So once we see the line scan, it's very difficult. There are opportunities to miss many things. So whether we need raster line scan or the volume scan to see most of the findings at the macula. Otherwise, we will miss many things. So this is one of the important things. I don't want to go details on that. I want to mention something which is already missed, I think, regarding the Dr. Sujit presentation. If we can remember the ETDRS study, the CTDRS study based on clinical and photographic techniques only. So they have treated the diabetic patients only on the photographs, on the basis of the photographs. So it's very important, and we have just to remember these things, that we always say it's for documentation only, to explain the patients only. Not like that. We can treat in many situations where we have limitation to use, this FFA and other even costly diagnostic tools. One of the important advancement in this situation is the multicolor photographs. If you see the colors, you can tell about the diagnosis also. So that is also very important, and which is available in many centers in Bangladesh also. So we have to keep in mind that color fundus program is not only for documentation. Dr. Aminu already mentioned its use of fluorescent angiogram. One question arised from our respected Professor Moshahid Thakur sir, that what is pseudofluorescence, what is autofluorescence, what is retrofluorescence. I think it is very, very important. Pseudofluorescence usually we don't see nowadays because it's the mismatch of the, our filter, and usually nowadays the instrument is such well equipped that mismatch is usually not occur, but it can occur sometimes. Say the properties of the fluorescence is we stimulate with the lower wavelength light, and it emits longer wavelength light. So if we the filter mismatch, the longer wavelength filter comes in shorter wavelength, so the longer wavelength get entry, and it will emit more longer wavelength light that will give you an artificial false fluorescent images. So that is pseudofluorescence. And retrofluorescence is something which is we can see when the RP is stirred or RP is thinned, like when RP is ripped, or any situation like the angioid stick or pseudo dentum elasticum, where the RP become much more thinner. We can see the retrofluorescence, which is we should know that autofluorescence is something different. You know, the materials which have property to autofluorescence, but you have to stimulate with shorter wavelength, and it will emit that deposition in the fundus will image the longer wavelength. I don't want to say anything more. I should thank Dr. Hafiz. He has presented very nice thing. You know, this is a very good alternative nowadays for many other tools, and also Dr. Shanur for his updates on Ingenuity, the 3D system. So as the time is very short, I should thank everybody for listening and also presenting, and the panelists also for contributing. Thank you very much.
Thank you, sir. Sir, now I'd like to request Dr. Tariq Ali, sir, to speak on OCT angiogram, which was presented by Dr. Hafizur Rahman. Sir, please. Sir, are you present, sir? Tariq Ali, sir. Tariq Ali, sir, are you present, sir? Professor Dr. Saifuddin Ahmed P2, sir. Sir. Okay, I think sir is present right now. Now I would like to request Dr. Ansar Haq, sir, to summarize the session and conclude the session, sir. Sir, please.
Okay, can you hear me?
Yes, sir.
Okay. Thank you, Dr. Sanjay, and thank you, OSB Scientific Committee, for including me as a panelist.
Sir, thank you.
And my all good wishes to my co-panelists. Actually, I'm very sorry I entered late. I missed most of the presentations. I could hear Dr. Hafiz's and Dr. Shanur's ones. So it's not probably possible to summarize all the presentations. But still then, I think I must congratulate OSB Scientific Committee for including this topic, imaging in ophthalmology, different modalities, because this is very important and we should all know all these imaging techniques. But one thing, what Professor Nizhat has mentioned, that all these are complementary. So nothing is, no one imaging technique is for any one particular case. So you may need one or two in one case, you may combine 3 or 4 in one case, even you may not need nothing in some particular cases. So it depends on your individual case. So first, I must say that the color fundus photography, it is a very important for documentation, for screening, for monitoring the disease progress, but it has limitations, you know, that it is, it cannot tell us about the microvasculature, it cannot tell us about the blood flow, it has limited resolution. So because of these limitations, fundus fluorescence angiography came. So that is the standard, gold standard, still gold standard, and it will remain a gold standard for some time future. Because that tells you about the leakages, that tells you about the vascular, pattern vascular, all these retinal vasculature, pathologies, normal retina, everything. But the problem is, as it gives a good image of the retinal vasculature, but it doesn't give much of the choroid. And because of this limitation, ICG came to visualize the choroidal circulation. But this combination of choroidal and retinal angiograms, they are still used. They will remain used for some time till we get a more better angiogram or a better imaging technique in the future. But here is also a problem. The problem is that this is invasive. You have to push the dye. It takes longer time. Cost is there. Patient phobia is there. And another important is there's potential complications. like severe allergic reaction, nausea, vomiting, many of these patients, this reaction comes. Because of these reactions, these limitations, they were thinking of a non-invasive technique. And that is where the OCT has come, which is a non-invasive technique of doing seeing the vascular retinal vasculature. But this OCT, it has double advantage, structural and functional. But the OCT that we have, the spectral domain, it only gives you the structural features of the retina, all the retina diseases, but it doesn't tell much about the functional thing, and that is where the OCT angiogram has come. That gives you both the functional and the structural changes. So this is just a sequence of the imaging processes, how they have come, how it evolved because of the limitations of one and the advantage of the other. So nothing is complete. So, but I want to suggest one thing, particularly to our youngsters. You must develop a very good clinical eye. If you have a good clinical eye, if you can make a good clinical examination, you may avoid many of the investigations in the primary stage. You may need them, but as you monitor the case, the progresses, you may have to go for some of these imaging techniques. But initially, it may not be necessary to go for all the investigations at the first time, second time. If you can make a good clinical examination, you note down your findings, and then you can see. So I would suggest to my youngsters that be a good clinician first, and then take the help of the investigations, this imaging techniques that you have. So combine these two, and you will have a very good anything wrong? No. Then you can have a good assessment of the whole case. You can monitor the case, you can make your treatment judgments of the treatment, everything. So I would suggest that and another one important thing is these imaging techniques, they are also very important for documentation for your medical legal, because nowadays these things are very important. You have to document your cases, because if anything goes wrong, then you have to be answerable. So these things are in short, and I'm very sorry I couldn't hear all the speakers. And I must also congratulate Dr. Shahanu for the heads-up 3D surgery that he has shown. I think this is the future, but for the now, I think it is much expensive, I think. So for all surgeons, for all these hospitals, it may not be available, but in the future, I think that can be. Thank you all. Thank you, OSB. Thank you.
Thank you, sir. Sir, we are end of the session, and I like to convey my heartiest thanks to all the speakers, our respective panelists, and all the audiences. And we are.
Tariq sir in panelist.
Sir,
Recording stopped.
Sir,